neurocognitive disorder, or as you're probably more used to hearing it discussed, dementia. I wanted to come back one more time to talk about working with adults, even though there's a general approach to AAC that involves consideration of needs as well as skills and barriers. We need to think about some of these differences related to adults. In working with children, we were focused on language development. With adults, we do want to focus on recovery wherever that's possible. But when we talk about adults who are using AAC systems, for those who don't have temporary conditions, a lot of times we're really trying to focus on quality of life and participation rather than reversing symptoms. So in this course, we're really on the compensatory end, especially when we're talking about adults. When we talk about dementia, saying someone has dementia is like saying someone has a fever, according to Bourgeois and Hickey. And I think that that's a good point. It's a pretty general description, doesn't give you all the details that you really need. The DSM-5 is now preferring the term neurocognitive disorder, and it's got a lot of different etiological subtypes, including Alzheimer's disease, Parkinson disease, HIV infection and related dementia, Lewy body disease, vascular disease, and each subgroup can be further divided up. So again, to use dementia as our umbrella term isn't quite where we are. Neurocognitive disorders more the umbrella term, at least as I see this developing. But we do still talk a lot about dementia. And the thing that you have to consider with dementia and technology is that we've got working memory, we've got ideas about learning a new piece of technology, and the idea that you're going to be taking in all this new learning and being able to store it for regular use is not something that a lot of times you want to lean on with people with dementia. You'll have to consider the stage that they're in. But you may want to lean a lot more on their skills with low-tech interventions. And so a lot of our discussion is going to focus on that today. We want to look at expressive and receptive language and talk about differences as they relate to memory as well. Michel Bourgeois makes an excellent point that I think you need to really keep in mind when you're working with people with dementia. Even when it's so advanced that people can't speak, they can still read if the words are large enough. The key takeaway I want you to have here is that print is going to remain very meaningful. It's just you're going to have to think about the amount of print and the size of the text. That's the key takeaway. And how do we know this? Well, we know because they smile, make pleasant sounds, and they stroke photos of loved ones with captions. So spoken words, in contrast, literally go through one ear and out the other. They understand, but they can't store these phrases in memory, and that's why they ask the same question again and again. So remember this, we're going to really lean on print and find ways that we can use it and continue to use it as the disease progresses. And the idea that we're going to lean on auditory messages, we want to try to get away from that, particularly as an exclusive channel. Let's talk about dementia in stages. And in early stage dementia, the caregivers learn they can support conversation and they don't challenge the person to remember specific words. They just focus on the message. So in this case, they're not going to be struggling all the time to say, well, come on, you know this, you can remember this. If the caregivers know pretty much what this person is talking about and a lot of the message is there, so there's plenty of context and it's fairly easy for the person to make determinations about what this person is probably saying, well then that's a good thing. We want to use things like memory wallets and reminder cards as ways to help support a person in early stages of dementia. In middle stage dementia, the person becomes less aware of the impact of their behavior on others. And what the caregivers learn is to help that person rehearse personal history information, and they shift their focus to meet the needs of the patient. Meaning, rather than, hey, I'm going to sort of let you do the things that you're doing, I'm going to focus on message, but you're going to be fairly autonomous here. This person's not as aware of the impact of their behavior on others. They want to figure out, well, what are your most pressing communication needs? Let's figure out ways to get those met together. And memory books are going to be the key thing you'll focus on here in middle stage. And in end stage dementia, you want to provide comfort and familiarity. The caregivers here learn to communicate for the patient and learn how to use language, tone of voice, familiar objects, and touch. It's so interesting for me to say the caregivers are going to learn to communicate for the patient. I think in this case, they're going to help interpret signals for that person. So that can maybe be said slightly more skillfully because we're not going to ignore what that person wants or needs, but the caregiver is going to make very informed decisions and help fill in things based on their knowledge of this person and that person's signals. So let's keep that in mind. And the memory books, we can still use those for people at end-stage dementia, but as I mentioned before, we're going to reduce the text, the amount of text, and we're going to increase the size of the text. Michel Bourgeois came up with an oral reading screening test called the BORS, and it helps you to determine the optimal font size and length of sentences. And I put a link to this on Blackboard so that you can use this. When you're choosing photos to include with memory books, it's important to be careful because the pictures that you choose could be upsetting sometimes for people. So photos of a lost spouse, for example, can lead to uncomfortable comments, uncharacteristic of past behavior. So you want to talk with family members about how that person is doing. Let's take a look at examples of some of these memory wallets as well as reminder cards. And wallets, remember, they can be small. We're talking about a lot of low-tech kinds of solutions here. We've got a caption, we've got our text, and then a reminder. And this is a way to provide a reminder for a specific time. And that clock is something that's going to be memorable for this particular person. Maybe as we move away from analog clocks, as the population ages, this will be different, but this is still a meaningful one for a number of people who learn to tell time that way. There's a set of books here. So we've got more of a scheduling one, we've got something about that person's life, and then we've got something that's more general memories about different things. So we've got a couple of different ways that can be sorted through. We have things here like we are going to Safeway, reminders about where a person is headed. These are things that can be done during the day. You can schedule these out so the person's aware of what is going to be happening, and it helps reduce questions that get repeated over and over again because the person isn't remembering something that you told them previously. You can write it down. We're going to Safeway. It can even be things like you're having a great day, which can also be reassuring for a person to take a look at. But we're going to Safeway, an important kind of reminder of what's happening, and these are things that you can easily assemble. You just don't want to overwhelm the person with tons of cards and books and things all over the place. We've got to be thinking about the categories of things we need and the number of reminders we have. So here's something done for somebody who's really in the early stages of dementia, just to give you a sense of how much print there's going to be there. we've still got photos throughout, and we've got print that's at a fairly small level, small font. In middle to late stage, we've got one photo here and some basic information, maybe getting to even a little bit less. Kinds of things that might go in my life or about me, kinds of memories. There are 3 principles to keep in mind with intervention with people with dementia. One, you want to maintain independent functioning as long as possible. So you want to support the person to stay employed and living independently for as long as that can possibly happen. You want to maintain their quality of life via supported participation engagement, so supports to stay involved in hobbies and their groups. Sometimes people can pull away when they recognize they're not able to participate in their card game that they've done each week. So I remember working with one person with dementia, and she really wanted to stop doing the card game because she felt like she was letting her team down. She wasn't playing as well. And so I talked with her about ways that she could still try to stay involved with that group of people. And if there were other things that they did, independent of cards, that she might feel better about joining them in, or if she'd still feel comfortable playing cards but not being there, but if she'd feel comfortable joining them to play cards but not actually doing it herself, she wasn't as interested in that. We want to find ways to emphasize personal relevance and contextual training. So in this case, you want to be addressing the things that are meaningful for that person. So lots of decontextualized practice of lists of things that aren't connected to that person's life or interest. That is not going to be what we work on for AAC interventions. How do you support memory? In early stages, we can use a lot of different technologies. You can use reminder apps, timers, other kinds of technology that the person might be using currently. So certainly smartphones have caught on quite a bit more, and people are carrying them a lot more regularly, even older individuals. And so we can still use a lot of these reminder devices. A calendar is still very functional. Those kinds of reminders help a lot. In middle stages, we want to modify technology, try to make it simpler, more obvious. You don't want reminders that are necessarily just on the computer and that require some more maintenance in how they get programmed in there. You want to find things that happen a little more automatically. If you go with wearable kinds of things, again, these are great, but you don't want a lot of the operational maintenance to fall on that person. So you have to think about things like charging and remembering to charge, and how you can keep that simple. And in late stages, you really want multiple sensory channels, including things that involve a lot of feel or tactile experiences, because that's so immediate and permanent. It's not to say that you don't want auditory stimulation, because music's still really powerful, and you can work with your music therapist in those cases. But the idea that you're going to rely on spoken language is a little trickier. Photos, familiar people, again, very powerful. I certainly encourage you to read the excellent chapter that Michelle Bourgeois did on Jane in the AAC casebook. And Jane's a 58-year-old female with progressive cognitive decline. And she still lives in her apartment, but has 24-hour supervision. She's an accounting professor. And if you watch, they try to work with numbers with her, and there are some things that still are going okay for her, and then there are others that she recognizes the challenge in. I think she experiences the frustration knowing, hey, I think this should be a lot easier for me than it really is. We still use the same approach. We think about what are Jane's communication needs, the who, what, when, and where, and we see that we really want Jane to still be out and involved in her community. We still want her to be engaged with the people that are meaningful in her life, and we want to be sure that she can talk about the things that are really most important to her. In terms of her participation needs, she's got to be able to interact with this full-time living caregiver, and they've got to be able to understand each other and their signals. Jane's got to be able to trust this person who's there, and when she's getting frustrated, Jane's got to still be able to talk through these situations with this person, and the caregiver's got to be able to talk back in sensitive ways without taking it personally. She does still have visits from her adult children and her sister. She has really starting to be more limited in her social partners and activities. And she does still participate in speech therapy. She doesn't have motor speech concerns, but her problems are related to cognitive and memory declines. She's got problems with word finding, and her reading comprehension is really starting to decline. A 7 out of 30 on the mini mental status exam. But on the plus side, when things are short and personally relevant, she still is able to make good sense of them, and that's going to be important when we think about memory aids for her. So we want to use a memory book. She can still make use of calendars. We can use those notes, the note cards with nice big print on them. She can use checklists, and when things are marked off, she can know, instead of asking again and again, she can refer to the checklist. And we want to keep things personally relevant. We picked a format, if you look in the case book, that we want her to still be able to deal with changing topics from communication partners or based on the things that she wants to talk about. So she has to be able to flip and accommodate different topics. Can't just be a book for one topic and then you need to find another book for another topic. She does well with large print and personal photos, and she does very well having a written daily schedule. In terms of her intervention goals, she's working on maintaining on-topic comments, and that can be tricky, especially if you're losing the topic and forgetting what is it that I've already said, or forgetting what is it that we're already talking about. And there you can make use of some partner-dependent strategies where you can write down key things about what your topic is, what's being said, those kind of strategies we had around written choices or augmented input to better track what's going on in the conversation. We're looking for her to attend activities with minimal cues, so to continue staying engaged with things. So when she's out in the community and when she's going out and trying to re-engage with things that are interesting to her, to still stay with the things that are happening. We're looking for her to read things out loud from the memory book and not to just consider them herself or to hand them to other people to read. Trying to get that regular practice with it to reduce some of the paraphasic errors that she's experiencing. And we're looking for her to respond appropriately to questions. Now again, it may be that she's going to be doing better when we've got some augmented input channels going, and that's okay in terms of her intervention.